And this week, we're going to be diving into Beyond the Bite, recognizing the acute symptoms of Lyme disease, getting an accurate diagnosis, and exploring acute Lyme treatments. So whether it's mastering tick bite prevention, acute symptom recognition, or conquering chronic challenges, we're going to be tackling it head on. You're not just watching a class, you're stepping into a community that's ready to rise above Lyme disease. And hey, if you love diving into these life-changing topics, smash that subscribe button and turn on those bell notifications, and let's make Lyme disease awareness echo across the globe. So grab your notes, ignite your enthusiasm, and let's roll. Are you ready? Let's dive right in. Hey everybody, and welcome. Thanks so much for joining us tonight. I'm super excited to see so many folks here and really pumped for, our Lyme Awareness Month. All the things we're doing together, sharing some really great information with everyone, making sure we get the word out so we can help everybody, stay as Lyme-free as possible in this day and age. So thank you all for being here. And hopefully our chat will be on. I can chat with everyone. There we go. If you'd love, I'd love for everybody to just say hi in the chat. Let us know where you're calling in from. It's always nice to know where folks are at. I am actually coming to you live from my mom's house. As many of you may have heard, we had a little family emergency, and I had to postpone last week, but we're back on track for the rest of the month, and everything on our end is pretty good. So I see, we've got Georgia, Long Island, Florida, which is where I am. Then I see New Jersey, which is where I grew up. I finished from West Hartford. No, well, great. Awesome. Saskatchewan. Wow. Great to see everybody here. Again, thanks so much for being here. Chicago, where Dr. Jess in our group is from, all over the place. Excellent. Kentucky. Phenomenal. Well, welcome everybody. Thanks again. For your understanding last week, family comes first. And I also, you're all part of my extended family too. So I wanted to make sure we got back on track. And so we're going to be diving in pretty quick tonight and just really going a little bit further. Let's see, we've got Boston and then April. I'll get to your question in 1 second. Vermont, Virginia, nice. The Catskills, St. Louis. Bethesda, all over the place. Wonderful. And so, so what's going to happen is I'm just basically pushing everything back by one Wednesday due to our little, mom deciding she needed to have a little look-see at the hospital. Thankfully, she's doing really well. Got a lot of well wishes, and really just want to say thank you to everybody for your wishes and your understanding. It happens to all of us in our families and stuff. So what we're going to do is we'll move everything back. So we'll be on every Wednesday in May, but then I had something scheduled with my daughter on that first Wednesday in June, and I think we're going to do the Thursday. I know we're going to do the Thursday. That'll be the 6th of June, and we'll be sending you out reminders of that. And the question was, hey, what's going to be up with the replays? And the good news is we're going to have all the replays up within 48 hours of us finishing our recordings, and usually within 24 hours. That'll be on our YouTube channel. So let's see if I can, before we dive in, I just want to make sure I give you guys the link to the YouTube channel. So let's do this to everyone, not just to myself. So this is our YouTube channel, and it'll give you a little quick, if you're not a subscriber already, it'll give you a quick pop-up that'll say, hey, do you want to subscribe? When you subscribe, that way you'll make sure you get that notification as soon as we post the replay video. The other thing is, once the replay is live, we will send everyone who's registered a link, not only an announcement, but the link directly to it as well. So hopefully we'll get to you multiple different ways. And as I said in our last session, if anybody has a moment to click on the link and just subscribe to our YouTube channel, helps us out a ton. It allows me to do more of this free stuff, and really the goal is to get the word out there, right? There's so many people suffering, and that's one of the reasons we're here, so that we can minimize some of that. So without further ado, I'm going to hop on over to here. And one of the things that is important tonight is we're going to be talking about, last time we talked about tick bites, prevention of tick bites, and then what do you do? Prophylaxis, like if you happen to be bit by tick, what are your options? What are the things you want to be thinking about? So for tonight, I want to talk about acute Lyme disease, how it presents, the testing that we could do, and the early treatment options, both the kind of the conventional medical approach, and if you wanted to take an herbal approach and you wanted to have a little bit more of that in your life, we certainly have natural approaches, and I'll be going over all that towards the end. So stay tuned for that. As a reminder, all the information we're providing you really is for information and hopefully a little bit of entertainment purposes as well. But really, it's to give you a framework of thinking so that you can have some questions when you do, if you do ever need to seek care from a physician or another licensed healthcare practitioner, that you're really being able to be armed with all that information. And unless you're already a patient of mine, this doesn't make us patients, but certainly love to, always, our practice is here to help you guys. And we're also training other practitioners to do the same thing. So hopefully we know that there's not enough people out there doing the kind of work that we're talking about here. So we're trying to train more of them as well. So that hopefully everyone who needs us, first of all, with the early diagnosis and early treatment, we can minimize chronic Lyme disease. And then if we get chronic Lyme or one of its friends, we at least have enough really well-trained providers. So that's really the goal. But as I mentioned, we did our tick bite tactics last time. Tonight, we're going to talk about beyond the bite and really what happens if you got bit, or in my case, when I got sick, you got bit, but you didn't know it. Really recognizing those early acute symptoms, figuring out like what diagnostics are really good, and we'll dive into some of the pitfalls that you commonly hear. Then we'll explore treatment options. And then for the rest of the month, and then now week 5 into June, we're going to be talking about the next 2 weeks. We'll talk about chronic Lyme, everything from the basics, the evidence behind it, and everything that supports how you can start really getting better, all the way through like sort of that emerging research that's really driving our advanced protocols, things like double dose dapsone, quadruple dapsone, disulfiram, tefenaquine, and things like that. And we'll talk not only about how to utilize that, but what the research is, like why are people even looking at it? So that, to me, it gives a lot of new hope. And then really my favorite is going to be that now June 6th, but week 5, we're going to be talking about breaking free. And really, so many people are talking about fight, flight, and freeze responses. And I want to help you have an access to and an option for, hey, what if some of these other approaches like DNRS or Gupta or Primal Trust might be a little too intense for you, or maybe you don't need a full-on program, but you just want a little extra you can do at home on your own for free that's going to help you move to the next level. So I'm going to share with you on week 5 the approaches I use with my patients, the approaches I personally use in my family life, and hopefully that'll be really helpful as well. So really excited to do all that. So when we dive in with acute Lyme disease, and I think this is really important, right? Why are we talking about acute Lyme disease and Lyme Awareness Month? And when we're talking about, primarily our target is looking at chronic persistent disease. And one of the most important things is you can't have chronic Lyme disease if you've never had Lyme. So as a physician who works with patients who have persistent symptoms following a tick bite or following acute Lyme, or maybe they don't know why, but they think it's Lyme, I always say, like, you can't have chronic Lyme without having had Lyme at some point. But so that can help me understand whether or not a person even has a possibility of chronic Lyme disease. But the other side is true, is if you happen to have someone just asked me if I started the recording, and it looks like I did. Hopefully it is. It looks like it's recording on my side here. So, but thank you for the reminder here. And yeah, sorry for the distraction, but that is one of the most important things, that we do get the recording for everybody. So thank you very, very much. Anyway, hey, Naomi, how are you? It's nice to see friends, and there's a lot of friends in the chat here. So anyway, one of the things for me is, it's not only that you can't have chronic Lyme if you've never had Lyme, but it's also like if we catch early Lyme, acute Lyme early, we have a much better chance of treating it. And so we're going to be diving a lot into that throughout our time talking about all this. So when you talk about acute Lyme disease, a lot of what we hear about it are these things like the fevers, the chills, all those kind of things. And realistically, like, a lot of people describe it as the summer flu, right? So you've got sort of what seems like flu in the middle of summer. And this, granted, we called it summer flu before we had COVID, but you get things like fever and chills. You might just feel like general malaise is like kind of the medical term for, I feel blah, right? But joint pains and muscle pains, you might have headaches or even a stiff neck if it's bad. But these are kind of the general symptoms that docs are typically trained, nurse practitioners, physician assistants, that we learn in school that just like kind of make us think about Lyme disease, right? So not the most specific thing in the whole world. Kind of sounds like a lot of things. But when we try to learn more about it, we're taught in school, hey, we've got early localized disease. So this will be early after the bite, maybe days to weeks afterwards. Near the bite site of a tick, you might have a rash. We'll talk about that. That's what the erythema migrans or EM is about. And you could have those flu-like symptoms. So really not very specific because, if I have fevers, I feel pooey, like I'm a little tired, some things ache, I might have a headache. That's not really helping us, right? Now, if you go into early disseminated disease, this is just basically meaning it's beyond that bite site. It's beyond just having the spirochetes in the skin leading to that red rash. You could have things like some of those really, like cardiac symptoms, Bell's palsy being a neurologic symptom, that facial droop. You could have uveitis or eye symptoms. So these are things where early on we tend to see more of those. But as you see at the bottom, when we look at things like months to years, yes, months or years after the tick bite, you can then develop arthritis and other neurologic complications. And so when we dive in week 3 and 4 in the chronic Lyme, we're going to be talking a lot about that arthritis because there's a lot of really good information there to help us. But for the meantime, some of the early neurologic symptoms that you should be aware of is, like I said, that facial droop. Like we said, people can have that stiff neck. That can get a little bit more, and it can be inflammation of the meninges, or kind of like the bag that surrounds the brain and holds all the fluid in. And if you kind of move around and stuff, like we've heard about meningitis, it can be really uncomfortable. Encephalitis, and that's the inflammation of that kind of the covering around the brain and the spinal cord. Encephalitis is actually inflammation of the brain itself. And then the biggest thing where we talk about those ocular symptoms are things like neuritis, right? Including optic neuritis. So you can have and all these itises are just inflammation. So you can have inflammation of the nerve going to your eye, and that can be problematic, right? The other thing is we can also see cardiac abnormalities. And in school, the thing we all learn about is, different type 2 heart blocks, that if you have a certain one, it's going to progress to type 3, which is we call type complete heart block. That basically means the top and the bottom of your heart are not communicating electrically properly. And that leads to things such as, arrhythmia. It is an arrhythmia. And essentially, in order to allow your heart to continue to beat properly, you may need a temporary pacemaker. So that is something that most people in the emergency room or acute care clinic should pick up on. But you can have inflammation of the bag around the heart or the heart itself. You can have LV is left ventricular. So the left ventricle is the largest sort of pumping part of the heart. Now the whole heart has to work together, but that's the one that's getting the blood throughout the whole body. So if you have dysfunction there, you can have some serious problems. And you can have cardiomyopathy or even sudden death. Now, these are really uncommon presentations of Lyme, but they are, when they happen, they're very acute. So it's kind of like you're not waiting a long time for these things to show up, which is why they come up in that early disseminated disease. And so here, one of the things that really comes up is, like I said, with early localized disease, people are looking for that bullseye rash, right? The erythema chronica migrans rash, or what most of us call an EM rash or bullseye rash. So this is kind of a picture from the CDC, one of the classic EM rashes that everybody looks for. The problem is there's two main problems. One is when we're looking at Lyme disease, everybody says, hey, the CDC says about 70% of people with Lyme will have the erythema migrans rash. But if you comb the medical literature, really what we're seeing is that in the medical literature, it's about 40 to 60% of people will have this rash. So if you call the average, it's 50%. If you call the high end, it's 60%, but it's not 70%, right? Which means, according to the CDC, 30% of people don't get the rash. According to the research, it's anywhere from 40 to 60% of people don't get the rash. So that's really important. So if we call it 50-50 for conversation's sake, for ease, that means about half the people don't get the rash.
But the other problem is, of the people who get the rash, only about 20 to maybe 30%, so let's just call it 30%, we'll be really conservative, in the medical literature get an bullseye rash. So if you look at these rashes here, all of these other rashes that are present, I'm going to move my face off of this one on the top right because it's really an important one. All of these are also physician-confirmed erythema migrans rashes. So, when we look here, we've got kind of this big central clearing with this sort of odd-shaped ring around it. And this is actually very much like what I had when I had acute Lyme, but it covered most of my left arm, most of my left chest, and most of my left leg, totaling about a fifth of my body, which I can't believe the doctor actually figured out it was Lyme. But that is a classic erythema migrans rash. You see this one over here. It's just like a red blob, and it's like kind of pinker in the middle, a little redder on the outside. And you see a secondary lesion. And if we zoom in on that, we see this right here. So you can have multiple large rashes, but none of them look like an EM, or excuse me, none of them look like a bullseye, but they are an EM or erythema migrans rash. We have another example here, and then the one where I moved my face off of here. This is really important. The rash is due to spirochetes, or the bacteria that causes Lyme, being in the skin, but it does not need to be at the bite site. So any of these could be at the bite site, but they don't need to. And up here, obviously, these are not all at the bite site, right? Unless you got bit by about 13 ticks all at once. So understanding that, one, you can just have a little ring with this big amount of central clearing, and they can be all weird, or you can have multiples. But you can have multiples of the purplish red splotch. You could have multiples of this one. So just be aware that all of these are possibilities for erythema migrans. And that's really important because you have to understand what you're looking for. So then the question is, I just kind of skimmed over in the beginning, what are we taught? But what are the real symptoms of Lyme disease when you see it? Well, in kind of layman's terms, in English, and the words that most people use, I've got joint pain, I've got muscle pain, things hurt. They're not going to say, oh, I have cognitive dysfunction. People are saying I have brain fog. I can't think the way I used to think. And in acute Lyme, it can be really intense and kind of right out of the blue. Numbness and tingling can happen. People can get dizziness. I should have changed syncope to passing out, but you can be dizzy and not pass out, or you can be dizzy and pass out. Both are related with Lyme, or could be related with Lyme. There are also many other reasons for that. Heart palpitations is really common, especially when Lyme disease affects the vagus nerve, which it has a lot of evidence it does. And so in week 5, when we do our healing session, it's going to be a lot about figuring out ways that you can help your own body treat Lyme and reboot your vagus so that it has better control over your emotions, better control over your heart, better control over your digestion, right? And then other parts of acute Lyme include things such as the shortness of breath that are down there, right? So let me see here. Boop, boop, boop. So there's a comment here that I stopped to look at. Rashes. The rashes are not known to be antibody reactions, actually. They're known to be, now you could have a rash that is, but the erythema migrans rash is actually bacteria that causes Lyme, the spiral bacteria we call Borrelia burgdorferi, or in the case of some of the other versions of Lyme, which we'll kind of talk about throughout this month, will be things like Borrelia californiensis, mayoni, spilmonii, and all these other newer species that are causing Lyme. But what we're finding is we're actually finding them inside. It's actually spirochetes. And when we talk about like chronic Lyme and stuff, there's all kinds of different evidence that we'll talk about. But one thing I want to point out with the rashes, since we're talking about them today, is that there are studies showing that if you have somebody with an erythema migrans rash that is diagnosed, you treat them with ceftriaxone, which is intravenous medication for Lyme. So for a rash alone, that is like way over the top. That's a lot of treatment that almost none of us would ever be offered. And not only for 3 weeks, but they give it to you for 6 weeks. 10 months after your rash resolves, they can go back and biopsy that. And approximately 2% of people will end up having living spirochetes in the site of where their red rash was before, even though the rash is no longer there. Lyme loves the fibroblasts in our skin, so that's one of those things. Let's see here, get back over here. And so the question really becomes for me is, when I go back here, I go, wow, that sounds like a lot of things, including COVID, including flu, including like I'm depressed, because that comes up in the differential diagnosis for doctors. It should come up. We shouldn't be offended by that, but they shouldn't be getting stuck on it when that's clearly not depression, right? But we've all, many of us have heard about that, where that, in fact, that's what I was diagnosed with. When I got the Lyme, I got treated for 10 days. I was sick for 8 years, and they kept telling me I had depression. I'm like, no, things hurt before I got mad and depressed, right? So one of the things that's really helpful is looking at Dr. Horowitz's MSID scale. He had the multiple systemic infectious disease syndrome questionnaire. There are very few things in medicine that are fully validated. Everybody's like, oh, you got to be FDA approved or this or that. Most things are not. So all the people are saying, oh, you're using a test or a questionnaire that's not validated. I'm like, most of them are not. But in medicine, there are a few validated questionnaires. And thankfully, Dr. Horowitz has one that is. And the key indicators, which I'm sure you've already read, are migratory joint pain and migratory nerve pain, which is when I say numbness or tingling, nerve pain, or paresthesias, we're all describing a similar phenomena. If we talked about neuropathy, which would be a biopsy, or an EMG sort of diagnosis, that's different. We're not going to see that moving unless you have it in multiple places, but this is the symptom that's not full on nerve breakdown, but it's irritation of that nerve, and that can move as well. And the reason that this is so important, and I would really say migratory joint pain is one of the hallmarks, because I've seen other things do weird nerve pain stuff. The thing that's so critical about this is the differential diagnosis, meaning what are the options for causing migratory joint pain, is exceptionally small. So we have inflammatory bowel disease, or IBD, which is like Crohn's or ulcerative colitis. Pretty darn easy for us to figure out, especially if you're coming in with all these symptoms. You have migratory joint pain and no GI symptoms, no gastrointestinal symptoms, probably less likely Crohn's, but we can also evaluate it pretty accurately. Then we look at gonococcal arthritis. So unless you have untreated gonorrhea, you're not going to be seeing this. And then hepatitis, right? Acute hepatitis can cause this as well as chronic hepatitis. But our testing for hepatitis is quite good. So we are able to figure all these out for you. And if we're not, hey, migratory joint pain is one of the most important things that we can look at. So this is a very helpful questionnaire for that. And then I spent a lot of my time, because I see about 50% of my patients are children, I spent a lot of time with Charles Ray Jones. By far the most, the doctor who has the most experience treating Lyme disease, period. And then in children, by far the most experience. So, and he died last year at 93 after a life of serving children and their parents who had Lyme. And he learned a lot. And one of the things he talked about so often when I was in his office, and I've seen this in my practice, is that about 50% of kids with Lyme will be presenting with a gastrointestinal complaint, belly pain, nausea, vomiting, diarrhea, all kinds of different things. Now, many children who have isolated abdominal pain, and they have terrible belly pain, they're yelling and screaming, they've got all kinds of problems, they've done the endoscopy, the colonoscopy, everybody's done everything, they find nothing. Very commonly, that's Lyme disease, right? And so the GI complaint thing can happen acutely. It crosses over a little bit to chronic, but if you have a kiddo who's got GI stuff and they can't figure out why, think of Lyme sooner than later. The other thing is in children is the neuropsychiatric presentations. We can have acute behavioral changes, regression. It can be social regression, school performance regression. It could be social stuff. It could be emotional. I have kids who go back and they start having baby talk and things like that. We can have tic disorders where kids are like blinking their eyebrows all the time. or, their eyes, they're grunting, they're breathing funny, they're doing flapping with their fingers, all the way to really big things. Lyme and even Bartonella can cause them on their own, or they can trigger an infection-induced autoimmune encephalitis, which we often call PANS or PANDAS. PANS is an acronym for Pediatric Acute Onset Neuropsychiatric Syndrome. Strep is essentially the same thing, or excuse me, PANDAS is essentially the same thing, but it's just letting us know it was caused by strep and not another infection. But the bottom line are, these are acute neuropsychiatric regressions. They can be caused by these infections alone, or they can have an autoimmune trigger. Then you have the infection and the autoimmunity, and you have to work on both. So that's part of that. We'll talk about testing in a minute, so I'll come back to that question. There's a question about, can you see uncontrolled hypertension in Lyme? You're probably not going to see it causing the initial hypertension, but if someone's kind of stable on blood pressure meds, they've been doing well for a while, then they get acute infection, you can certainly see dysregulation of that. Dysautonomia, which we'll talk about a little bit more in the next couple of weeks, but it'll be where you don't have the, like where you stand up and you get dizzy, right? And a lot of people call it POTS, or you're having a racing heart rate. That can come from Lyme and from Babesia. And certainly a part of that would usually be more low blood pressure rather than high, but I could certainly have seen people where high blood pressure can get a little bit, less controlled than it previously was, for sure. Yeah, and it's interesting. Then there's a question from Gail about, like, her daughter had joint pain, and it looks like it says PAC, but I think back and shoulder pain and leg pain. And certainly those are super common for all the infections that we're going to start talking about, because next week we'll start talking about Lyme and friends and all the co-infections as well. It's interesting, like a lot of times people will have, particularly not so much with Lyme, but more with Babesia. And the reason I kind of pause for a second is it's really hard to get babesiosis without concurrently getting Lyme. You can do it, but it's really also hard for us to figure out the difference, particularly once you're out of the acute phase. So deep breaths and the sense of air hunger and needing to sigh, or not really getting that full wonderful breath in, or just having to take huge deep breaths, can all be part of that dysautonomia, the dysregulation of the autonomic nervous system, and controlling that. So that can be part about it, and then we're going to talk about, chronic sinus stuff typically is not Lyme, but one of the biggest things we end up doing is, we're mouth breathing, we're exposed to mold, we're pretty much okay. We get Lyme, it's the straw that breaks the camel's back, and now we've got mold illness and chronic sinus stuff and, other mouth breathing, which is all going to make your nose a lot more congested. And then you're going to have those together. So that can be part of it. So, and there's so we're going to dive into the testing part and what sounds like Lyme and not in a second here. And then, more about biofilms. Certainly we're going to be talking about biofilms quite a bit starting next week. Talk maybe a little bit tonight, but definitely next week. So when we look at acute Lyme disease, we need to look at, like, what are we doing with diagnostic testing, right? And you'll hear Dr. Jones, if you see any recordings of him when he was alive, talking about this. You'll hear just about everybody say this. I've actually found it in Harrison's textbook of internal medicine and paraphrased a whole bunch of other places in physician references that Lyme's a clinical diagnosis supported by lab data. So essentially, what that means is if it looks like a duck, it quacks like a duck, it's yellow, it's got orange feet, and it can swim, hey, it's probably a duck, right? But we say it's supported by lab data. The problem is we want to get the support, but our labs aren't that good, right? So let's dive into that, because I don't want to just say things and not have the evidence to support it. So commonly what we recommend is that we do this ELISA or an IFA antibody screen. And if it's positive or borderline, equivocal, then we confirm it with a Western blot. And so when we look at this, that's what most people call the two-tier testing methodology. So when we look at that, you can look over here and you go, oh my God, the specificity is basically 99%. And the sensitivity is 56%. And you're like, well, wow, what does that mean, Dr. Tom? Well, sensitivity and specificity are challenging things to look at, but we're trying to figure out if we tell you you're positive, we're not missing a positive, right? And if we tell you you're negative, we're not missing, we're not getting too many false negatives and too many false positives, right? The problem is when you look at, so basically what this means is if I tell you you do have Lyme, it's almost 100%, right? But if I tell you you don't have Lyme, the problem is if I take 200 people, I could miss 88 true positive people with this approach. So if you want to do the screening and then confirm it, and you want to, and you're positive, it's, you know, or I should say you're positive, you are positive. But if you're negative, it's a 50-50 that we missed you, right? And so that's a problem. And just a little public service announcement, there are people in commercial laboratories who know this problem, right? And I spoke with a guy who's the CEO of a lab company from Italy who's working on combining antibody testing B cells along with T cell testing. They've gotten it up to over 75% sensitive while maintaining this high specificity. They, believe it or not, despite the fact that they could go to market with it because it's clearly 20 plus percentage points better than the approach that I'm showing you right here, they're like, it's not good enough. And I think that that's really important to know that there are people out there who literally their job is to get this test to market as quick as possible. And they're saying, even though they've improved the testing by more than 20%, it's still not good enough. And to me, I'm like, that's like an hallelujah moment, because here the industry is saying that we need to do better and they're working on it. So what are the challenges with that test? Because it's an indirect test or an antibody reaction, right? So we're measuring your immune system response to an infection. Couple of challenges. One is it's not going to be positive for a couple of weeks to a month or so after you get infected. So if you get bitten and you pull off the tick and you start to get the summer flu and you go to your doctor and your doctor goes, oh, here, you have Lyme disease. Here, start on your doxycycline. I'm going to draw a test. And they call you 2 days later. Oh, your screening test is negative. Stop the doxycycline. Asinine. That is not when that test should be done. It's too early. If they think it's Lyme, it's Lyme. You know, in an acute situation, if it looks like Lyme and you're in an area where there's a bunch of Lyme, it is Lyme. And let's just treat people. My niece was treated for over 5 years for acne with minocycline. At the same dose I would treat someone with doxycycline or minocycline for Lyme disease acutely. Why can't I give you 3 or 4 weeks of that to prevent a life of problems where if it's for vanity's sake, we're okay? You know, it just doesn't make sense. Now, if you happen to say, wait 4 to 6 weeks and you had a good antibody response, the problem is if you wait too long, the antibodies go up and then they go down. They go up and they go down. And we have published information on untreated patients as well as people who were treated or partially treated. So we know that this is a challenge, right? So the antibody levels will change. You know, when you look at what are the tests, we look at an EIA, you know, an enzyme immunoassay, or an ELISA test, or an IFA. If I move that forward, they're the most common tests that we're going to start with. The C6 peptide is kind of a souped up version of this. It's quite good in Lyme. It's better than an ELISA or its other friends, but it's still not great. Where it does have more utility is if it's elevated, it could be Lyme, but it could also be Borrelia miyamotoi, which is a tick-borne relapsing fever species similar to Lyme, but causes symptoms that look like Lyme, anaplasma, and babesiosis all rolled into one. So if the C6 is positive, but the Western blot, the confirmatory test, is negative, it may not be Lyme. It may actually be Borrelia miyamotoi. Only challenge there is, like I said with babesia, really hard to get Borrelia miyamotoi without concurrently getting Lyme, because all the published studies we have of ticks that have Borrelia miyamotoi in them, they also concurrently have Borrelia burgdorferi, aka Lyme disease. So the challenge here is if we're seeing a C6 positive and the Western blot follow-up is negative, it could be Borrelia miyamotoi. We should check for it, but it's also probably just Lyme, right? And if we're thinking about doing the testing in an area where Lyme is really prevalent, we should probably just be treating it. And we also have T cell testing, which is when someone mentioned, hey, Armin is a lab in Germany, and they offer T cell testing as well as a tickplex. And a Plex is supposedly looking also at persister antibodies as well. And Leona Gilbert worked on that. So that's a next level test that could be helpful, but it's still along the same lines. The other part of T cell testing is it's not the antibody side of your immune system. So we're looking at another side, and both Armin as well as Infecto Labs, and to a smaller degree, IGeneX will offer those. So again, it's probably not the best acute test, but it is a test that's out there. And then we look at Western blots that are typically the ones that we follow up, and that's what we were talking about here. If you hear immunoblot, Western blot, or Lyme blot, they're all the same test. They all mean essentially the same thing, except when you talk about something like an expanded immunoblot, and that's a term I decided to use because IGeneX will use things like immunoblots, but they're actually looking for more than just Lyme. They're looking for other species that cause Lyme-like symptoms across the board. So if you're looking at a Western blot or a Lyme blot, or even at Quest, they have an immunoblot, they're typically looking at this laboratory strain called B31. IGeneX in their basic work will add in 297, which is just another strain of Borrelia burgdorferi. But then they also look out and they're like Mayoni, Californiensis, Spumoni, Avzeli, Guerinii, all these other species that can cause Lyme-like illnesses that are essentially Lyme disease. They may be missed by your commercial lab. So when people are like, hey, IGeneX is more positive than other places, I think they're wrong. They're looking for more than your standard blot. So they don't really offer a Lyme immunoblot. They offer a Borrelia immunoblot for non-tick-borne relapsing fever, because all the tick-borne relapsing fever species are Borrelia too, just to be really confusing. But they offer that separately. So when you're looking at one of these specialty labs, they offer more, and they're looking for more. So that's probably why people, in the beginning, people didn't like, it wasn't like Quest and Perfect or LabCorp and Perfect. But now that we know more, we know that there's other species. Like there's a lot of patients that had an isolated, they would have a positive ELISA test, IFA, EIA, whatever one it was done. It was positive. They go to the Western blot. They've got a 41 IgM band, but they don't have a 39 or a 23. And if they had one more of the others, they'd say you have acute Lyme. For decades, we told those people it was all in their head. But for some research people, we stored their blood. And in 2014, when we learned that Borrelia miyamotoi could be a human pathogen, within 18 months, they went back and they found over 300 different people who fit the criteria for Lyme disease, but their Western blot was negative, primarily with just a 41 band, and they were found to have Borrelia miyamotoi. So they may or may not have had Lyme disease, but they definitively had Borrelia miyamotoi. But for 30 years, we told them they were crazy and they didn't have anything wrong with them. And that's a challenge. And so we're going to come around that next week and the week after with chronic Lyme and what's the difference between chronic Lyme and post-treatment Lyme. But just know the testing is not perfect. I mean, Babesia duncani, the genome was only sequenced about 8 years ago. That's not that long ago. So all the tests need to catch up with the new information. So just not to belabor it, that's indirect testing. Now, direct testing is like the gold standard in infectious disease, diagnosis, because we're actually finding the organism or a piece of the organism. So PCR, we say has a low sensitivity, but really the more important thing to me is positive and negative predictive value. Meaning if the test is positive, is it positive? Well, in Lyme disease and in most infections, if your DNA is positive from a reputable lab, meaning they have good primers and they're actually checking for the organism you think, then you're usually in good shape and you have a high positive predictive value, meaning if it's positive, it's really positive. The challenge is with DNA, it's negative predictive value, meaning if the test is negative, is essentially zero, because you either have the disease, but we missed it, or you don't have the disease, but I don't know which one of the two it is. And really the challenge here becomes we're looking for blood, we're looking for pathogens that travel in the blood, but love to be in the tissue in the blood. And we do that because we can't just check every tissue of your body, because if we did, you wouldn't be alive anymore. So that doesn't help. So we need better approaches, right? So then we have, when could a direct measure be really good? Well, in acute Lyme and co-infections, it can be really early in disease, like very, very early. That's an important thing to understand. That is a time where this indirect testing method may not be good. Like I say, may not be positive for several weeks, but this stuff can be positive really early because it's in that transit stage where the Lyme is circulating through the body. So that can be helpful. Now, I'm talking primarily in blood here. There are some urine tests out there. There are a couple of urine tests, like IGeneX and Galaxy, offer some that are pretty decent. There are other labs that offer your urine tests for DNA of things. I would run away. I would never touch them. They're not validated, and the primers have been called into question by many, many, many physicians. And you don't want the wrong answer. We need to know what's wrong with you. If you do have Lyme, we need to know it. But if you don't have Lyme, I want to know that too. So other things we can look for are things like culture. We've had cultures on and off. Lyme disease and other Borrelia species are exceptionally difficult to grow in culture. It's not that people don't want to offer you a culture. It's just exceptionally difficult to do. Then more recently, we've had things like CE PCR, which is culture enhanced PCR, where like IGeneX offers this, they will culture the blood for 6 weeks and then check the culture and then check a PCR. So they're looking to amplify the DNA through growth and then through the PCR polymerase chain reaction amplification process. And maybe that increases our chance of calling a true positive, like finding it and not missing it. But it's still not perfect. The other challenges, or the other good news, I should say, is with the pandemic, lab testing got fast forwarded into the future by probably decades, if not centuries. We now have digital droplet PCR that people are working with that allows us. The problem is, like, if you do if you do a study, right, we can run a PCR 40 times, 40. And if one of those are positive, it's considered positive. Most commercial labs will run your DNA test once. With the CE-PCR at IGeneX, they run it 3 times. So we're still 37 shy because it's so expensive. With digital droplet PCR, we're able to run many more samples for less money. And so we can increase our ability of picking up the true positives and the true negatives by doing that. But again, we're looking for organisms in an area where we might not be able to find them. So the summary is your clinical suspicion, the physician's clinical suspicion is most important, and direct testing may be best in the first couple of weeks, like right away after a bite, because we're actually able to find it while swimming around. The indirect testing is probably better 4 to 6 weeks out. The problem is if we go further than that, how do we know where you're at when you're in the up and down, that sine wave of IgM responsiveness? So it's just something to know about and think about. And then when we look at chronic symptoms, because we're going to be diving into those quite a bit, clinical suspicion is kind of, again, the number one. Indirect testing can be super helpful for us. And then there is a possible role for direct testing, and we'll dive into that kind of as we go through the month. So one of the things I would suggest is avoid this screening test followed by an immunoblot. If your doctor is going to do an ELISA or an IFA or an EIA or whatever the heck antibody screen your hospital offers, just ask them to order both, because so many people are missing and we don't want to miss. So just get both of them. It's a lot easier, right? And, direct tests, if you're done early, please remember, early in disease, specialty labs suck at this because it takes forever to get a test result back. Their testing is great, but you want the test right away. Quest, LabCorp, ARUP, Collaborative, whatever they are, their DNA testing is standardized for Borrelia burgdorferi if you're looking for Lyme, and Babesia microti if you're looking for that. This is what you want, right? So this gets you a quicker insurance-based result, and it's much more helpful for early diagnosis. Again, IGeneX, great DNA testing. It's going to take 7 to 10 business days if you're lucky. And that's business days, not the weekend. So, and it's going to cost extra. So if you're going to do both, that's fine. But just think about Quest, LabCorp, good stuff. And, the Lyme multiplex that they do and the culture enhanced PCR test from IGeneX, 6 weeks. Multiplex PCR and whole blood is really good. You can order that, but it's going to take a while and be much more expensive. And then the digital droplet PCR, there's more new testing coming out, not just hopefully beyond just Bartonella from Galaxy. So stay tuned for that. Again, summary, we miss a lot of stuff with indirect tests. Places like IGeneX do a good job, but again, it's a borreliosis immunoblot, not just Lyme disease, which is one of the reasons it's great. We're not missing things, or we're missing less. If somebody is going to order this at somewhere like IGeneX, we look at serology, which is just our antibody screen, IgM, IgG, and we have our immunoblots like we talked about. And then again, you can do extra stuff over at IGeneX if you want to get really fancy and do their souped up screen or their immunoblot. So the speciation. And just be aware that those are just add-on costs. But again, not needed necessarily for acute. Acute, the best stuff is to send a bunch of stuff to Quest or LabCorp. And I will say, like, with the question of direct, boy, I had to go back further than I thought. Indirect versus direct. They can order all of them acutely. I mean, acutely, we can get these things being higher, right? We can get these tests to be there. We can get them to help us, and antibodies sometimes change over really early. But if they don't, let's not miss it. So do the direct. So that's kind of our overview of the symptoms of acute Lyme and our testing. Let's dive into a bit of treatment here. And let's see. I'm just looking at a couple of the questions. Yeah, there's a couple of really great questions that we will talk about in the Q&A. There are other lab companies that I have not mentioned, and I'll leave it at that. There's a reason I haven't mentioned them. I'm not going to be calling people out. Question is, do you recommend testing the tick immediately and wait 4 to 6 weeks to test? I'm assuming a person. And what should we test for specifically? I do personally, I don't really recommend testing the tick and then waiting and then treat it just assuming that in 4 to 6 weeks we should test the person. Typically what I would say is, if it's a high risk tick bite, which pretty much any tick bite in the Lyme endemic area is, if it's a deer tick, I would offer prophylaxis, as I talked about in our previous session, based upon that person's unique history. And that might be, for them, it might not be indicated. It's not indicated for everybody. The second thing is, I think all ticks that bite you should probably be tested, because you can go to somewhere like tickreport.com and for $50 know whether it had a pathogen or not. It doesn't tell you whether or not you got a pathogen in you, but it certainly told you whether or not it was present in the tick. The reason to test a person is they have symptoms. There is no other reason to do a Lyme test. If you have an asymptomatic person, there is zero reason to do a Lyme test. Now that I said zero, because you never want to say never or always, right? If you're a person who's recovering from persistence of infection and we're confirming that your lab tests have become negative, then that's a different story. But if you're an asymptomatic after treatment for chronic infection with positive lab tests, and now you have you now have a negative test, that's probably a good sign. But if you're asymptomatic after a period of treatment and you still have positive labs, that is not necessarily an indication that you need to continue treatment. There's a lot of nuances that go into that. We'll touch more on that as we go through the rest of the chronic Lyme weeks. But again, that's where you really need a physician who knows what's going on. And that's why we have the Lyme disease practitioner certification and mentorship program, where we teach that, because that's not basic, right? But in general, if you don't have symptoms, you should not be getting Lyme testing. And if someone's waiting to diagnose or treat you with Lyme, they probably shouldn't be doing that, right? Now, if they say, hey, the tick probably was on you for an hour, we got the tech, the test is positive for Lyme, but you've had no symptoms, and it's been a week and a half, we really would like to initiate prophylaxis within 5 days. It's longer than that, and we're going to watch and wait now. And the reason we say about 5 days plus or minus a little bit is because at that point you're infected or not, right? So most likely it's gone somewhere, and you're going to start to see symptoms creep in. Now, again, not 100% of the time, but it's just a general way to look at it as a starting point to have the conversation. But, waiting to see if you develop symptoms, if that's the clinical decision, is fine. But testing for the sake of testing is really not a great idea. With that said, most people are doing that style of testing indirectly, waiting for your antibody response, but you shouldn't have that unless you're sick. If you do happen to be like, hey, I'm asymptomatic, but I got a positive Lyme DNA test on a blood test, means you've been infected with Lyme in the last 2 days. Now, the question of whether or not you should treat a person with no symptoms, who's if they don't have symptoms, apparently actively clearing it on their own, that's a whole nother story. And I would usually, sit down, and that's a longer conversation. So if we're going to do treatment with acute symptoms, typically the standard of care doxycycline, and it's typically going to be by the book, 3 weeks. For those of us who treat acute Lyme and have an understanding of its long reproductive cycle and the potential for chronicity, we usually are going to start with 4 to 6 weeks, and then we're going to reassess, right? So none of these open-ended antibiotic protocols, even if you've been on chronic Lyme treatment for 7 years, you should probably get reassessed every month or two to make sure you still need that treatment, right? So it doesn't mean that we're going to take the treatment away. It just means we're going to double check you still need it. Alternatives I have listed here, because it's important. Not everybody can handle doxycycline. You could get sunburn. Minocycline, there's very little sunburn, but you can get staining of your skin. It typically starts in your legs. It typically is very long in the treatment. But acutely, you could have dizziness, right? Cefuroxime and Ceftonir are also cephalosporin medications. They work well. Amoxicillin is still a great choice for acute Lyme. Depending upon your body size, that 500 might need to be 1,000 or even 1,500 twice a day. And then azithromycin, commonly used in Babesia treatment, commonly used in persistent Lyme treatment. The reason I have parentheses there is it wouldn't be my first choice for someone for acute Lyme, because there is some evidence that not all North American strains of Lyme are effectively treated with azithromycin by itself. So don't take the chance in acute disease. Chronic disease, we're doing so many combinations, it's a bit different, right? Then the other thing is the conventional treatment, like I mentioned, is typically 3 weeks. Some people are still stuck on 10 days to 14 days. But the problem is, if you infect the monkey for 6 months and they've done it again at 4 months, and then we give you 28 days of doxycycline, we cure 0 monkeys. And if we give you 28 days of ceftriaxone IV intravenous, and then we give you 2 months of oral doxycycline, we cure a whopping 27%. So when I go back to this one, I'm like, well, unless I'm 100% short, because we don't really know what the optimal is between time 0 of infection and 6 months, right? But I'm probably not going to hedge my bets on 10 knowing this, right? And the longer someone's had symptoms acutely, the more I'm going to err on what I said earlier, which is I'm going to give them a month and reassess them and see where we're at. So I would consider the extended courses, but again, it's based on your unique physiology and your response. So one of the other things I wanted to talk about as we wrap up, kind of like the didactic, if you will, the talking head before we dive into the rest of these amazing questions, is what would I do if I wanted to look at herbals, right? And so these herbs, Cryptolepis, Polygonum cuspidatum, which is Japanese knotweed, and Scutellaria bicalensis, or Chinese skullcap, have been shown to be super effective against growing and non-growing Lyme. In fact, they've been shown to be better than doxycycline and cefuroxime against Lyme. So why not consider using them either as part of your treatment or as your only treatment, right? And the combination of the three are great for Bartonella henselae, and Chinese skullcap, or the Scutellaria, and the Cryptolepis combined are also really, or individually, are also really good, at least in test tubes, for Babesia duncani. So here, this says acute Lyme formula. Well, the thing is, the reality is it's probably really damn good for Bartonella and Babesia as well. Now, hasn't been studied in Babesia microti, which is much more common than duncani, but, clinically it seems to work. So let's keep an eye on those, but maybe that's a thing you can do. And often this is a lot easier to get your hands on. Typical adult doses are roughly 40 drops of each 3 times a day. That's assuming a 1 to 5 extract, which is kind of the most common one. I like Lyme Core Botanicals, Woodland Essence, and or BioPure as my sources. And I'll talk a little bit about adjusting for children in a minute because they're not just small adults. Other things are, if you like something like Beyond Balance, they have BB1, BB2 for Borrelia burgdorferi. And then usually acutely, I would use BB2, 15 drops 3 times a day. Vital Guard Supreme is a chrysanthemum extract. We talked last time about permethrin, which is great for repelling and killing ticks. There is an herbal chrysanthemum extract called pyrethrum, similar, not as good data on it preventing ticks on you. And so I would use the full toxic chemical that dries and is non-toxic on my shoes and socks. But Vital Guard is essentially pyrethrum, but in the full chrysanthemum thing, and it's a capsule. So 2 capsules 3 times a day for adults. And then, Cryptolepis 30, 40 drops 3 times a day would be a good way to go. And then again, we might want to adjust dosing for children. One thing I love to remind everybody about Cryptolepis is it tastes like crap. Most kids don't like it. Some will take it. If you happen to be a Byron White person, you could substitute AL complex for BB2. You might be somebody who's got research nutritionals around with your Cryptolepis in with red root and lomatium and a few other things. It's a little easier it's a little more palatable. So you might want to substitute Crypto Plus. And you could use things like whole leaf artemisia or liposomal artemisinin. Probably not the best bet for acute Lyme, but they're decent for babesia and for biofilms. But again, like if you're going to add a few things in, consider it. And then you could also add into this formula Japanese knotweed and or even cat's claw. I haven't mentioned here, mostly because cat's claw is not good for acute growing Lyme. It's good for persister forms of Lyme. We used to always use it thinking it was great for growing Lyme, but it's really not. And when we get into the talking in the next couple of weeks about the other approaches to chronic Lyme disease, we're going to talk specifically about the research that I'm drawing all this from. So stay tuned for that. Now, thanks to Dr. Alexis Chesney. She's got this great book on preventing Lyme and the acute treatment from an herbal perspective. Great resource. She has this formula, which I found to be really helpful for approximating what you would want to do for kids. So you basically take their weight, you put it over the ideal adult weight of 150 pounds. I don't know who made that up, but it's what we use, about 70 kilograms. And then you would assume if the adult dose is 30 drops, you would just do the ratio here. You would know the kid's weight, and then the only thing you'd have to figure out is what their dose would be by doing some math. But, if you look up here and it says 15 drops, well, then you can just put, instead of 30 drops, put 15. If you go over here and I said 40 drops, then you just go down here to your formula and you substitute 40 for 30. So it's pretty straightforward. Again, whenever you're dosing anything with children or adults, I highly recommend you work with someone who actually knows how to do it, not just do it yourself. But these are good ballparks that should keep most people safe. So that's what I've got in terms of like the overview. One thing I wanted to say before we dive into the questions and answers, really, I just want to say thank you so much. One, for your understanding last week. That's, as you know, family emergencies happen when they happen. And I had to make the decision to be there for my mom and hop on a plane and, change everything around. I really, really greatly appreciate that. And I appreciate you all being here. There's great energy, spreading the word. Our YouTube channel is growing. We're getting more of the word out to help, because the thing is, there's a lot of chronic Lyme. There probably will be for a long time. But the number one way to minimize chronic Lyme is to start identifying tick bites, ways to prevent Lyme from tick bites, and then in this case, acute Lyme. So I wanted to say thank you. And for anyone who's interested, if you head over to our website over at Origins of Health, and I'll get my little thing out of the way there. If you go it's just originsofhealth.com. If you go to the top, you'll see this thing that says free resources. And then you go right down here to, when you hover over it, it'll say top 5 supplements for healing chronic Lyme. If you want to hop on, you'll get to download this this really cool resource. Oh, I thought I had there we go. There's the cursor. Yay, free resources. Go down here, you'll get that. And what you see here actually in the background, and I'll probably show you this in the next couple of weeks in detail, but it's a summary of which herbs are known to work for growing or stationary forms. And stationary forms are another word for persister forms. And so I'll show you for Babesia, Bartonella, and Lyme disease what it's known to work for, so that you have a better way to understand where to go with all this. So hopefully that's helpful for everybody. Thank you, Gift, to you for being here. I really appreciate that. And as a reminder, we just got done Beyond the Bite. We're going to dive into 2 weeks of a really deep dive into navigating chronic Lyme. We're going to talk about the tick-borne co-infections, sort of the old tried and true effective treatments, and then we're going to dive into some more of the advanced treatments. I want to make sure that you have an overview of kind of the lay of the land out there, so to speak. So that's all to come. And I'd like to say a huge thank you. I really like I always look for different cool things to throw up, and I just like the white humanoid body reclining and relaxing. So while we have to think about this, while we have to dive into it, we don't have to stress out. We're all here together. And that's why the big thank you, because this is a village, and together we can make a huge change. So big thank you to all of you. I think there's all kinds of different things. So one thing I want to throw out there, maybe we'll just ponder it for a little bit, is what's going on with research and compliance and doctors getting on board, and really, are there plans underway to create Lyme disease research organization that might follow a model of the Indian Health Services, basically as a disenfranchised community? And then, how could groups like Lyme Disease Association, the International Lyme and Associated Diseases Society, ILADS, even LymeDisease.org and Global Lyme Alliance, I'll add into that, like, how could they support this mission? And so I'm going to come back to that one. I want you guys to ponder, and if you have any thoughts about how we could get the other people out there to help us, really, so that the gaslighting stops and then we get to this point, and I mean, I guess I said we'll hold off, but one thing I do want to say, just to be sure everyone knows, is I've recently been at different scientific research symposium where it's there's a few clinicians, but they're mostly just academic clinicians. They're working at the big, research places. They're the names that you read on papers, some of whom you might think are Satan. Other groups, I've even sat down at this conference with people from Moderna and Pfizer, and not that I agree with them, but it's like they're looking at what the community is experiencing. They're understanding, like Diasorin is the group that's doing this lab testing. They're like 76, 78% is really good, but not good enough. And even the old school researchers from the 70s, 80s, and 90s, who are kind of like the evil players, sort of in these Lyme wars that I think we need to stop having. But they're actually seeing that new research is showing that most of what our chronic Lyme patients are experiencing is actually validated by scientific evidence. And I would suggest, this is my opinion, I'll talk way more about this in the coming weeks, chronic Lyme disease, there is more evidence of chronicity of Lyme than there is of cure of Lyme. And anybody who wants to show me papers to disprove what I just said, I welcome it. But I can tell you, having looked at the medical research, there's very limited evidence of cure, and there's a lot more evidence of persistence of infection. Now, we also have persistence of symptoms, which we'll talk about in the future. But the reason I wanted to, I kind of got sidetracked there for a second, is I think it's really important for you to know that the science is leading the way, and the scientists don't like the fact that we don't know the answers. I talked to a group out of Ontario about, I don't know, probably 12 or 14 weeks ago now at a different meeting. They said that they've done research on Lyme biofilms, and Borrelia research across the globe has never found fibrin in a Lyme biofilm. And they're like, that's interesting, because everybody says fibrinolytic enzymes, systemic enzymes, are necessary for Lyme biofilms. There's no evidence that that's true. Now, that doesn't mean there won't be evidence, but what they said was it's gotten us thinking about patients are using it and getting better. We're not arguing that they're getting better from using it. What we're saying is the reason that a lot of people say it's working probably is not true. And so they started researching why it might be true. And I mean, these are sort of middle of the road researchers who are just seeing people suffering. And one of the researchers I talked to personally has chronic Lyme, very vested interest in it, right? But they're not saying like, oh, it doesn't work, throw it out the window. They're saying the patients are reporting this. Our science is not supporting why it would work down one pathway. Let's go to another pathway and find out what the hell's going on so we can help people get better faster. And I'm seeing that across the board. And what I'm seeing more and more and more is, like, when you look at the CDC, right, they say about 80% of people get better from Lyme with any treatment, 10 to 21 days. But the other 20%, they're crickets. They don't say anything. You look at the latest research, 75% of people get better, children get better in 6 months. But the other 25% can be sick for up to 10 years. So we have evidence that probably what one group is saying applies to about 75 to 80% of people. And what a lot of us are experiencing, and people like me who do this as a, every day, day in, day out, and personally suffer with chronic Lyme and chronic babesia, we also have a part of the truth. So what ILADS and LDA and LymeDisease.org are saying, and what the rest of the people are saying, probably are not different. But it's like, if you close your eyes and someone had you stick your hand out and they said, what are you feeling? Like, well, I feel a trunk and it's got these 2 little holes and it feels like this long thing. I think it's the front end of an elephant. I feel like the little hairs. But if you had somebody near the back end, like they feel the tail, well, it's really thin and it's nowhere near a trunk. Maybe they grabbed a leg, right? We all are looking maybe at a different point, a different place. That doesn't mean that any of the groups are wrong. It just means they may not have all the information. And as a person who doesn't give 2 shits about who has chronic Lyme and who has cancer and who has hypertension, but I want to know what it is so that I can help you get better, because I'm not wed to the diagnosis. I just need to know what a diagnosis that is your diagnosis is so you can get better. And I'm happy to tell you you have hypothyroidism rather than Lyme all day long. But if you don't have hypothyroidism and you have Lyme disease, I'm happy to tell you that too, because now we have an action plan. And to me, the most important thing is better diagnosis. So as a person who just wants to know what's wrong so we can help you get better, irregardless of what the problem is, I'm really happy to see the communities coming together. And the thing that pisses me off, though, is it's taken forever. And it's taken patients arguing, yelling, and screaming and suffering. And I don't know why that happens to do that now. I thought I turned that off on Zoom. But what I know is that the science is leading the way. And groups like the Global Lyme Alliance and people who are donating to, including many celebrities, to Global Lyme Alliance, they are funding the research that is changing the face of this. So one of the things I suggest all the time is supporting Global Lyme Alliance, even if it's just so you let other people know. And then if you happen to know you can do this on Zoom, if your thing is turned on, there's 2 other cool things you can do while we're goofing around for a minute. So we can have a party here and celebrate the small but substantial momentum and wins we've had. And a big thank you to everybody for being here, right? And for, it's so funny, these things. So, let's see, if someone had a tick bite on and off chronic fatigue, OCD, ADHD symptoms, and something about urine mycotoxins, Armin was negative, what I do IGeneX too. I often use IGeneX. I don't always use it, but if you've had a tick bite and then you develop symptoms of like chronic fatigue and ADHD that you didn't have previous, and OCD, I would definitely be looking at the possibility of tick-borne infection, and things like the phenomena of PANS, that infection-triggered autoimmune encephalitis. That can be it. PANS can also be triggered by things like mycoplasma, chlamydia, strep, candida. So it doesn't even have to be a tick bite to lead to some of those other symptoms, But yeah, I would definitely be talking to someone like, hey, where's the best testing to be done? The thing with Armin is I think of them as T-cell testing. I know they do other stuff. If you did a tickplex and it was negative, maybe it's not Lyme disease, but there are other co-infections there as well. So it's a great question. There's like, if spirochetes are in the rash, would an antibacterial cream or antibacterial essential oils help to kill off some bacteria? I don't know if anybody studied it. I typically can't get topical antibiotics quick enough for it to be used on the rash. But what I will say is I have seen people have swollen knees that persist for a really long time. And even Ray Jones told me, oh, the knee may stay swollen even if there's no more Lyme. And I'm like, I don't like that answer. So one of the things I've done is I researched topical antibiotics, and a lot of times, like for cats, because like you can't put stuff on the back of their neck here, and if you put any, they can reach almost everything. And getting a pill in a dog is pretty easy. Getting a pill in a cat is next to impossible if you like your skin and you don't like to bleed to death, So one of the things they do is they'll make antibiotics and they'll rub it on the inside of the cat's ear because it can't get in there with its tongue and its ability to turn its head so much. So what I started doing is using topical doxycycline on the knee. So if I had somebody with a persistent swollen knee, it's not in place of IV antibiotics or oral antibiotics or whatever is indicated based on the case or the herbs, but it's an adjunct. And I found it to be very helpful in people who have persistently swollen knees and their symptoms are isolated. So could we then extrapolate and say, I think what it's doing is treating the Lyme that gets in the synovial membrane, the lining of the knee. So you could certainly be looking at potentially using an antibiotic cream. But again, it would probably want to be a prescription strength made by somebody who knows what's happening. So, but that's a great question. That's definitely something that I think we all need to be looking, considering. And I also would love, and maybe I'll think about asking Global Lyme Alliance to support that. What in terms of finding out if we can study that. Now, is it possible to have let's see. So if you have a Lyme infection, then you had Armin, which was a weak positive. I'm assuming that's the T cell weak positive. If it's not, you can just shoot me a little message. I'll try to find it between the chat and the Q&A. But if you have a weak positive for Lyme disease and you have symptoms for Lyme, again, I go back to it's a clinical diagnosis supported by lab data. Weak positive tests typically often will mean that the antibodies are going up or they're going down because they naturally fluctuate up and down. The other thing it could mean, is that your immune system is suppressed from infection and or other stressors. So you're not just making a full response, right? And then you also have to check, does someone have like something like a common variable immunodeficiency like I do? My parents gifted me with low functioning immune system in a certain way. But it's just, and I'm thankful to say I'm doing really well with it. It's not a big issue, but other people don't have enough IgG or IgM to actually have those tests be valid. So that's another thing to think about. So biofilms, again, just a reminder, we're going to talk about that a lot in the future. So if I recommend tick, oh yeah, we talked about that. That's good. But definitely get the tick. I would definitely think about getting the tick tested early. And then just to clarify, like if I'm doing a Quest, if I see somebody acutely and I do a Quest PCR, I will probably do antibody testing, at Quest because it's all going through your insurance. You get it all at once. I do not routinely go back in 4 or 6 or 8 weeks later and repeat antibody testing. The time I would do that is if someone develops symptoms. But if they have a rash and then we treat them and it all goes away and nothing's happening, that's already a diagnosis. I'm treating it. If I'm doing prevention, I'm not going to go back and do it unless they develop symptoms. So again, why are we testing? We're testing to confirm our diagnosis or to rule it out, and also that it would change what we do. So if I think you don't have Lyme and it turns out you do have Lyme, that's going to really change what I do. So that's why I kind of take that approach to testing. What does a 34 band on IGeneX or any other test that happened, like a MDL in New Jersey, will also offer that, and several other places. The 34 band is analogous to outer surface protein B. So when we look at surface proteins in Lyme, there's about 64 of them. We only really talk about 3 or 4 of them. The 3 common ones are OSP-A, OSP-B, and OSP-C, which is short for outer surface protein A, B, and C. The 31 band is analogous to A. B is going to be that 34 band. And then the 23 band is going to be outer surface protein C. So the importance is, in order for, in the tick is where the 31 and also the 34 are prominently expressed, especially the 31. The 31 is so important to Lyme disease that's what pretty much all the vaccines have been based on, because they want the tick to suck the blood, have it go, or the blood from you go into them, your vaccinated blood, and then it will neutralize the spirochete while it's in the tick before it even gets to you, which is why they're using 31. Now, once the spirochete, the Borrelia burgdorferi pathogen is in you, in order to infect you, it needs to shift its outer surface proteins and express 23 on its surface so it can infect you. So 23 is a more noticeable band in you. So when I see like a Quest IgM 23 in a human, like I'm like, man, you probably still have Lyme floating around. It's either acute or it's chronic and you've seen it recently. Doesn't tell me the difference, but that's really what it means. When we go back to 31 and 34, those are typically not going to be expressed on the surface of the bacteria that causes Lyme, that spirochete, for 10 to 12 months when it's in you. And this is actually one of the conversations a lot of we were having is people are like, well, OSPE is not expressed in humans. And I'm like, there are people in the room that are right across from you who published on this in the 90s. But then we also have newer papers that came out and that was actually corrected. And the person who was saying that never happens changed their mind after seeing the research. And that really feels good to me. So 34 probably means that whatever spirochete your bacteria, your immune system is reacting to has probably been around for 10 or 12 months or more, right? And so it doesn't necessarily indicate a new one, but it could support our diagnosis of chronicity. So I haven't read the whole question, but I think I love this question already. How about a family where almost everyone except one is positive for Bartonella, and every teen in the family is symptomatic? Some have Lyme, also have Lyme. Does it make sense to test and treat the younger kids or wait and see if symptoms develop? That is a phenomenal question, and thank you so much for asking it. I'll answer when I was with this story, but when I was studying with Dr. Jones, because I have a ton of experience. I've seen well over 5,000 people with these things. You know, he had 30,000 plus kids by the time he passed away. So when you can lean on the shoulders of giants and climb up on their shoulders and go to the next level, it certainly makes a big difference. But Dr. Jones was saying like, hey, and I met the child that he was talking about. He said, so like dad was okay, little Johnny was okay, but you know, Jane and Bobby were really sick and mom was super sick. When they did their testing, they had what I affectionately call wishy-washy Western blot. There's a little bit here, indeterminate there, positive there, but nothing really made a full Lyme positive Western blot. Symptomatically, slam dunk Lyme disease and co-infections, right? So then they go, hey, Dr. Jones, should we test Johnny? And he's like, well, does Johnny have any symptoms? And they were like, no. And he's like, well, then no, because if you don't have symptoms, you don't test. And if you don't have symptoms, you certainly don't treat. So, you know, several months go by, they come back, they go, hey, Dr. Jones, we went to the pediatrician. We told them to order the IGeneX and it lights up like a Christmas, like everything. I'm sorry about that. I swear to God, I turned this off 2 weeks ago. Apparently I did not save it properly. So he said like the kids' Western blot was like almost 100% positive, like every single band, right? And at the time, IGeneX was doing 12 bands on their Western blot. So like 10 or 11 were positive. And they go, see, so we need to treat him. And he goes, does he have any symptoms? No. So how are we going to know when treatment's over? We won't. If you have no symptoms and we treat you, what is the most likely thing to happen? Side effects. So the moral of the story was that the immune system can fight off Lyme disease. And in fact, probably 75 to 80% of people, whether you do nothing or whether you do any of these other things like 10, 14, or 21 days of antibiotics, will probably do okay, right? It's the other 20%, and they're the ones that we're all working with, and they're the ones with the wishy-washy Western blots most commonly. So typically, if we don't have admission criteria, we don't have discharge criteria. In fact, my mom went to the hospital and they're like, look, she doesn't need to stay, but she doesn't have a safe discharge home because of her inability to walk, but it's not a hospitalizable problem. So they did a thing they called observation, you know, and they observed her to see if it was going to get worse or it was going to get better and then get her over to rehab. But she had no admission criteria to the hospital. And the problem is when you admit people to the hospital who don't deserve to be admitted, you usually end up having them stay really long and developing hospital-acquired problems. Same idea goes to the testing is if we don't have symptoms, we shouldn't be testing and we shouldn't be treating. Now, in the scenario where the whole family is exposed, or most of them are, would I be highly vigilant to see if the other child was developing symptoms? Absolutely, 100%. Stay on top of it. But if you don't have any symptoms, I mean, maybe this is one person whose immune system fought it off, or maybe they weren't exposed. A lot of families where I see Bartonella, but not for sure Lyme, I would look at either lice if they're of school age, and the other thing is really commonly spider bites. So a lot of people are exposed to Bartonella that way. So if you just kind of an FYI, if it happens to be in your environment, be aware of that. Quick question about, can you put tinctures in empty capsules? You absolutely can. Depending upon the kind of capsules you get, often they're going to melt quick. So you're probably going to have to do it at the same time, but you can certainly do that. The question of like acute Lyme Formula 1 for kids, is there a chance to have Herxheimer reaction with that? I would say any of those. Whether you're talking an antibiotic, any herbal combination, they all have the possibility of Herxheimer reactions. More properly put, it's a die-off reaction or a treatment reaction. When we're killing the organisms, all hell breaks loose for a short period of time. That can certainly happen with herbs and medicines. And for every time I think I've seen nuclear Armageddon with antibiotics, I turn around and herbs do it to somebody too. So it can happen on both sides, and absolutely with those formulas. Let's see. It's a question about Dr. Talks. Dr. Talks is just a group that puts out summits. I am on some of their summits for other people. I'm going to be doing my own summits on my own, just because I find that it's direct to you guys rather than through a third party that is going to be flooding your inbox with a bunch of extra stuff. And yes, quick question about the website in the chat. I'll put that there. And I'm looking at the Q&A right now, guys. I know there's also a big chat there. I will try to skim that as well. To the best of our knowledge, we treat Borrelia afzelii and Guarinii, Borrelia mayoni, californiensis, Spilmonii, all of those the same way. And actually, our tick-borne relapsing fevers like Borrelia hermsii, Borrelia terracate, and Borrelia miyamotoi are all essentially treated the same way as we treat Lyme as well, at least from an antibiotic perspective. No one studied it with herbs, but I use both, and we try to put them all together. Ticking, for tick tests, I typically do tick report. There are definitely other organizations that do a good job. Some are more or less accurate. I don't keep a track of all of those because primarily my folks are on the East Coast, and tick report's really easy. I know there's some in Pennsylvania and such, but the thing is, as long as they're using a proven DNA methodology where they've purchased their primers from a reputable company, then DNA is totally accurate, right? We have the whole tick, we can grind it up, and we're also looking at the genetics. The problem is when we have these specialty labs offering tests that no one else can validate, and they're getting a result that no one else on the planet gets, the problem might be their primers, and it's just not an accurate test. It's not the DNA is the problem, it's the primers. For all the ones that I've seen come across my desk that I don't have memorized, all of the tick testing places, especially the ones that are associated with departments of public health, like Tick Report is UMass Amherst, but there's a few others. They're pretty darn accurate, right? Is the only reason not to test because of money? It depends on the scenario, but no, to me, it's like if tests were free, would you just test everybody? I would say 1000% no way in hell. Because the problem is there are a boatload of people exposed to infections that treat them off on their own with their immune system. And if you test most people in Connecticut, they're exposed to Lyme. If you test most people, they're exposed to Bartonella. And it's becoming more and more common. What you need to do is have testing is not definitive, right? Now, if you get a Lyme culture or a DNA of Lyme disease in the blood, because tissue is different depending upon the type of tissue it is. But if you get that, that is proof positive, right? It's DNA in the blood. It's been alive in the last 48 hours. But most of our tests are not looking for that because that's not a very accurate testing model. So we need to have clinical suspicion, labs, or excuse me, do something like the Horowitz MSIDS questionnaire, one of the other questionnaires. If it looks a lot like Lyme, then we should start to look at the testing, right? Especially in a more chronic phase. In an acute phase, if it looks like Lyme, just go for it. But part of the problem is we have co-infection, we have other things. But if we just tested a ton of people who were asymptomatic, you'd find out that they were exposed to Lyme. And now what do? You have a positive test, no symptoms. You treat them, you make them sick, and they weren't sick. So it's challenging. And it's like Ginger Savely, who's well known for her work in Lyme and Babesia, as well as probably even more so in Morgellons disease. She took the CD57 and she said, hey, everybody's using it to diagnose Lyme. Is that any good? Well, if you have an 80 CD57 and your number goes down to 0, or your number goes up to 200, those are all the exact same number, right? Actually, I should probably have said, if you have a 121 and it goes down to 1, or it goes up to 241, those are the same number. There is a 120-point swing, and it's the same number. So she took people 3 times in a day, 5 days in a row to do that research. That's some scary shit, right? You could just do a CD57 and it's really high, but you feel like crap and you feel, oh, I should be feeling better. That's not true. It's really low, but you're feeling better. Oh, I'm going to crash. Well, that's actually not what the lab test means, but almost everybody who gets a low CD57 and feels good and says, I think I'm going to crash, they do. That's not Lyme, that's your mind. And so we need to understand what we're doing with these things, right? So now if people are symptomatic, definitely there's nuances to testing, and testing should be done. And if it was all covered or free, would I do maybe more in certain people than I do? Yeah. But have I figured out a way to not break the bank and still get the right answer? Absolutely. So again, kind of a riff on the same thing. Hey, if I say you don't have symptoms, then I certainly don't treat. Wouldn't testing and treatment be to be on the safe side still makes sense? If the tick was on the body for a minimum of a certain period of time. So the problem with that certain period of time is we don't know what that certain period of time is. If it's a nymph or an adult, 3 to 4 days, the nymph falls off usually in 4 days, the adult 5 to 7, depending. But around day 3, you're starting to get, if it's got Lyme, it's over 75% transmission rate. And day 4, it's over 95% transmission rate. But the flat ones, the problem are we don't know when you get sick. We don't know when it gets transmitted because it could be in the salivary glands. Research shows about 4 to 5% transmission from an infected tick to you in day 1, but that's not 0. And we have case reports of less than that. To me, it's like if you get a tick bite and you don't have symptoms and you want to pursue preventive treatment, which is prophylaxis, then treat. Because prophylactic treatment, it's almost like what do they call it? PrEP, pre-exposure prophylaxis for HIV. A lot of people I know who are homosexual or heterosexual are using PrEP, and they're doing it like before, during, and after an exposure. But they don't know, even if somebody has HIV, they don't know that they got it, but they're doing it to prevent the transmission. So if you got bitten by a tick and you want to prevent infection, because presumably you've removed the tick so it can no longer transmit. But if it transmitted and the Lyme is circling through the blood trying to find tissue to live in, yeah, treat the hell out of it. You don't even wait for testing, But what I'm saying is if you have someone like in the scenario of like tick bite was 6 months ago, if they don't have any symptoms, there's no reason to test them. And then all the other things we said a minute ago. So thank you. That's a really great question because it helps us figure out the difference between prophylaxis and treatment of symptoms. So everything I've said tonight about not testing and not treating, except where it's really specific and saying when you should use direct or indirect or whatever. When I say don't just randomly test and randomly treat to be on the safe side, that's for people who have the exposure was a long time ago. 6, 8, 12 weeks, 6, 8, 12 years, or months or years. But if it's a preventive thing, go back and watch on the web on our YouTube channel. It's just youtube.com/OriginsOfHealth. Go check out the replay of that came out with this month session, because that'll highlight, and that's what we're talking about, prevention, right? So it's a completely different ball game, but it's definitely, I'm so thankful that you asked that question to really clarify that. What do I do for people who can't tolerate die-off and prevention, and not able to tolerate treatment? There's a whole bunch of things that go into that. We're going to be diving into that for the next couple of weeks, so I'll probably dive into that for you more specifically there. I typically find that in those situations, we either have the wrong diagnosis, and by that I should say the wrong primary diagnosis. But when we do have the right primary diagnosis, it could be we're doing too much too quick. It could be that you don't have enough energy to actually tolerate it. And we've done things like methylene blue 5 milligrams once a day for like 8 months, and that's it, right? I mean, something really simple to help rejuvenate the mitochondria, help promote intracellular autophagy. This is a place where what I'm going to teach you on week 5 will come into play, because we're going to be using breathing and mindset to turn on self-healing in a way that boosts the immune system, that promotes autophagy, but you can tolerate, and it also is a way to do limbic retraining and vagus nerve training that will allow your central nervous system to accept the change in treatment. The biggest thing, and we'll dive into this, is we have to stress the body in order to heal, but we only need to stress it a little bit and not too much. Because if we do too much, your body goes from safety and familiarity to unfamiliar territory, which, hey, getting better after 10 years is great to be in that unfamiliar territory. But if we go too far in unfamiliar too quickly, our body registers that as lack of safety, and it will pull you back. And I've seen so many people, they get like rapidly better, 4, 6, 8 months, they're like 70, 90% better, and then they just go wham, and they get smashed back. And part of it is we went too fast, and or we didn't do the limbic retraining that was necessary. So I'm going to give you a whole session on how to sort of cheat and get around that, and then be able to kind of do the next pieces. So great question. If you test positive because you had symptoms and we treat you effectively, will you always have positive lab work? The answer is you should not have positive IgMs forever. There are a very few people who do have very persistent IgMs. Almost all of them go away, but not 1,000,000% of people. But your symptoms, obviously we're talking about chronic Lyme this month. Not everybody gets 100% better, and there can be some permanent damage as well. Yeah, a lot of people will completely clear their blood tests and be good. Now, from a Lyme perspective, the IgG may never go away. And the problem is IgG may never happen. IgG may happen, and if it does happen, it might go 100% away, it might partially go away, or it might never change. And we don't know who those groups of people are until we see. So the IgG will help us with the diagnosis. I wouldn't look at that for Lyme long-term. IgG in Bartonella is a completely different story. That's more of the acute phase, because IgM may come and go and other things. So just know that that's a place where it's a little bit different. The pathophysiology of migratory joint pain, I think some of it is we don't know, and some of it is spirochetes can move. Sometimes spirochetes start to act up in one area, the immune system starts to go after them, a few die, a whole bunch go up into persister forms, and then they open up somewhere else because of a thing called quorum sensing, where they're kind of chemically communicating to help, continue their living and everything. The other thing, though, is Lyme causes a lot of inflammation. And as inflammation travels throughout your body, you may have different systems. Like for me, like both knees hurt, but my right knee hurt way more. I had injuries in high school and college that put my right knee at greater risk, and it had some swelling before Lyme. It was worth throwing Lyme. And then afterwards, the left knee is fine. The right knee was a little off, and I had to do other things to fix it. So if you have pre-existing things, the inflammation in and of itself can do it, and then the migratory things, let's see, can be part of that. So those formulas I discussed, where can you get them? Things like Byron White and Beyond Balance and Research Nutritionals, you should not be able to purchase on your own. It should be only through a provider. I believe Marty Ross offers Crypto Plus on his website. I don't know how, because they don't let me do that. But the other ones, you can actually, our store at originsofhealth.com, at the top, we have a little store button. Any of the other formulas like the Vital Guard Supreme, the Cryptolepis, Japanese Knotweed, Scutellaria, we offer through Lyme Corp Botanicals. There's also a foundation formula with the Japanese knotweed and Chinese and cat's claw in capsules. That's there as well. So definitely start by checking out our website, and you can look there. Yeah, so if you test a decade after, one initially got sick, should you do 2-tier? I wouldn't personally. I would just go to a blot. But if somebody orders a Quest test on you and you have a 23 IgM and you have a really high screening test, and you have the symptoms of Lyme, that's enough to support that. And let me see. I just see another question about the website. I can drop the link in there for you, at least to get you started. Oh, here you go. So that's our store that has a lot, but not everything. Yeah, there's a huge debate upon what the most clinically relevant bands are or whatever. The big thing here is 18, 23, 31, 34, 39, and maybe 41, 83, 93. They've researched this crap forever. The bottom line is we're looking at parts of the problem, not the whole problem. None of the testing matters. Doesn't matter a damn bit if you have symptoms, right? So then you have to work with someone who knows how to interpret those tests. I mean, we spend weeks and weeks and weeks on this in our Lyme disease practitioner certification program because it's confusing. That's why we're trying to get antibodies plus T cells all in the same test. I'm trying to get somebody to make a T cell DNA, the T cell test, the antibody test, and the DNA test all in one. People are working on it. So great questions about that. Thank you so much. If you develop the symptom of treatment refusal, most of the time that's kids, not adults. I mean, what can be done to help them, especially if psych drugs aren't working to calm the symptoms? It's hard because a lot of kids and adults get treatment fatigue. Without knowing all the details, and I know who posted that, so I might know some more details. I think the best thing is to not break their stones. I think it's to lead by example. Anything that you think that they can do to help themselves, model it. You are an amazing, amazing influence over your partners, the adults around you, the teenagers, the children. Even when the kids are giving you the bird and they're pretending they're not listening, they're listening, right? They're looking at you. So I would say cut back to the bare minimum. I know that this is kind of going to be blasphemy to some people, but if someone's not willing to take stuff, find out one thing. I had a schizophrenic that would take helminths once every 2 weeks. The only thing that they would take. They started a whole bunch of other stuff, got a lot better, and quit all of it. I could get them to take these worms once every 2 weeks. It stimulated their microbiome enough that it stopped them from having suicidal ideation. They had had previous suicide attempts and hospitalizations. And I picked one thing and had them commit to that. And then what you do is, if you're sick too, because a lot of times it's in the family, or you're not, but you want to model for them, hey, I'm going to I take my vitamin D every day I take my probiotic every day. I'm eating better food. I'm doing the exercise that I want you to do. You model the behavior and give them the opportunity to participate. But when they don't give them shit for it. Just do it. It's like the same way. How do you get your kids to cook? You get them a knife and a cutting board. You let them practice a little. They get bored of it. And then you just give them the opportunity. You ask them if they want to help you cook. If they do, great. If they don't, let them quit. If they want to cut onion or pepper for like 4 seconds and leave, great, let them do it. If they prefer baking over cooking and you want them to do something healthy, like my daughter does this a lot. I'm like, hey honey, like just here are the guidelines for making it healthier than just some boxed sugar full thing. You know what some of these things taste like from us, healthy desserts, from your friends at school when we're not around. You've tasted the crappy stuff. Make something with healthy ingredients. Provide the healthy ingredients and then let them have a field day. But I cannot overemphasize how powerful leadership by example is. And also unburdening the child of all the pressure, or the adult. There's times I don't take my supplements because I feel pretty good, but I got to take them because I want to stay feeling well. and I get back on track. But it's like, if they're refusing after they've been doing it for a while, find a way to partner with them, I guess would be, and without more details, it's kind of hard to know. But, and then low and slow to prevent a Herx reaction. Yeah, and then the question is, hey, if I do that, will quorum sensing, efflux pumps, and biofilms, effectively hide the spirochete? And we don't know what to do. We don't know the best treatment. We know that a lot of the herbs we're using are hitting growing and non-growing, including the biofilm forms. The problem with low and slow is I've had people be on 1 drop twice a day for 6 months, and they're not really symptomatic, but they're so afraid to move. A lot of times what I do is I'm like, go faster until you prove you can't handle it. I would rather you have a huge Herx and not like me for 4 days and then be better than just dilly-dally. So you have to find a balance. Now, the super sensitive people, the people who've proven time and time again, they can't move forward. Look at that. One of the things I'll talk about later in the month is bioenergetic therapy. And this is one of the things where we can check how the energy is flowing through your body and where your battery is depleted. And we can improve that so that you can handle the treatments. A lot of people are just jumping into chronic Lyme treatment without setting a strong foundation. People crash over and over and over again. So either I put them on methylene blue for a long period of time, or I give them these bioenergetic scans, and we fine tune personally where your battery is drained, and we optimize the communication in your body. I've had people 4 or 6 weeks into, drinking like a formula we make once a day with salt water and vibration. And they're doing this 6 weeks in, they're better than they've been in the last 5 years, despite all the antibiotics, all the herbs. Now, does that mean those things didn't work? No. What it means is they didn't work when they were taking them. It might have done the work, but we didn't see any results, so I went somewhere else. But if you have the ability to fix the energy early on, so I'm going to give everybody here an opportunity to have the experience of what those types of things are. And that's maybe one of the tricks. That's a great way to not Herx. It's a great way to get kids who don't want to do their treatments, or adults who are sick of it. Because a lot of times if you put a little salt water in something and you drink water, or you drink like an iced tea or whatever their favorite juice is, or put it in your smoothie, you don't even notice it's there. And in a couple of weeks, you're feeling better. Statistically, in 4 weeks, like people's wellness score goes up by like 50+%. And it's just because we're helping balance the energy so your body can do the work. Make no mistake, you do not cure Lyme disease with anything you put in your mouth. I'll repeat it over and over and over again to anyone who wants to hear and doesn't want to hear. It's not about what you put in your mouth. It's literally that helps your body. But when we treat infections, we unburden the immune system and we support it so that it can do the work. Whether it's pneumonia or any other thing, even cancer. I mean, cancer is a little closer to completely eradicating the cancer, but your body still needs to keep it in check. So we need to support your system to respond properly. And so we're going to dive a ton into that in weeks 4 and 5. So yeah, and thanks for all the questions that get me going. I love it, So quick question about IgG levels in mycoplasma. When I studied with Dr. Jones, he unequivocally said IgG means nothing in children other than they've been exposed. IgM is mandatory for proving that they have currently active or reactivated mycoplasma. Now, in my experience, high IgGs can often, in the 4s and 5s, may suggest mycoplasma, but really we're keeping it in mind. And when we know that there's been an exposure to mycoplasma that could cause a problem, we're looking for things like doxycycline or azithromycin, chlorothromycin that could also treat it when we're treating something else. All the cases of PANS where I've seen like acute food restriction, anorexia, like all these crazy behaviors in kids, they have all had positive IgM mycoplasma. So thanks for that question. Great one. IgG may go up and down and fluctuate over the course of someone's lifetime. So we can't always, we can't always take care of that. And it doesn't always mean active, except Bartonella. Bartonella that went away and then the IgG came back is a different story. The big places, and if you want to look and research on that, look at Bartonella and look at Brucella. And most of what we know about treatment and labs of Bartonella are initially coming from Brucella research. because brucellosis is a much more of a bigger acute problem. But it also is one where if you treat it for 6 weeks with doxycycline, you have something like almost 50% relapse rates. If you do 10 months of 2 antibiotics, you still got over 20% relapse rate. And to get under a 5% relapse rate, you need to do doxy, Bactrim, and rifampin for 18 months. And this is well established. So, you know, and certainly alkalinizing can help if you're in pain or inflamed because you're acidic. You know, an alkaline diet, what's really interesting, if you're having a Herxheimer, one of the best ways to alkalinize your body is to acidify your GI tract. Because so it's funny how we use the terminology, but yeah, definitely stay on top of, if you're eating like a whole food, plant-based diet, you're getting, you know, you might use some bitters, you might throw some lemons and limes in when you're having a Herxheimer or whatever. All of these things work to balance this stuff all out. Thank you for the thank yous. Yeah, and then, you know, the thing is there's a lot of conversations about research and where we need to do more. And, you know, it's interesting. The research of Monica Embers, I touched on a little bit this week. We'll talk more about next week. But yeah, Monica Embers and I actually have talked a bunch about this. I'm probably gonna have her on my podcast. She gets it. One of the things, a lot of the research being funded is being funded by the Global Lyme Alliance. And one of the things about them is they saw they were supporting science. And when they saw they were supporting the science, they realized that they weren't talking to the clinicians. So, but people like Embers and a lot of other people, like they were seeing that they knew a bit, but they needed to have that collaboration. So Global Lyme Alliance actually made a medical advisory board to help them figure out what questions clinicians are asking and need to have answered for their patients. And then when you get the results of the scientific studies, how do we educate people about that? And like, what's it actually mean? So there's a lot of work being done. Definitely check out the stuff that they're doing. You know, let's see what else. Yeah. Well, and there's questions about like, how do we get research done? What's the best way to do it? And the word circumvent was used to circumvent standard research. I don't know that we need to, I think what we need to do is come together and we need to take the sides and realize that we're both looking at a different part of the elephant, but we both own a piece of the truth, but that's not the whole truth. And what we need to do is focus back on patient-centered medicine. And that is clinical evaluation, clinical innovation, personalized love, tenderness, and care, and also not throwing out science because it doesn't tell us, it doesn't say what we want. It's just like this, let's just keep ordering tests till we get an answer we want. That's bullshit. That's not good testing. If we have a shitty test, let's get a new one. But I think we really need to focus on advancing the field. And we have to advance the way we look at research. And a lot of people, you know, and COVID certainly has helped drive some of this. COVID has also shown us the wrong way to have a conversation about vaccination. That's an abomination, because if I had a conversation with Dr. Horowitz about how he treated people with COVID, I got censored. We never said this is how you should treat COVID. We made a statement of fact. In our charts, you'll see we did this. You can come pull our charts and you see that that's what we did. That's a statement of fact. But you're censored if you don't agree. And part of science is being open to opinions that aren't yours. And the possibility that truth may be different. So if we're going to ask the people who are sort of the people who say chronic Lyme doesn't exist, an IgM 31 band is not found in human specimens. If we're going to ask them to be open to change their opinion because new science emerges that is different than their original research, their original opinion, if we want them to change, we also have to be open to change. And so, like I say all the time, I do not care what's wrong with you. I really am not attached to it. I see a lot of Lyme. If it's Lyme, I want to know. But like I said last time, and I say almost all the time I talk, I've had people come up from Florida to Connecticut. They flew all the way up there. They spent all this money to see the Lyme expert. I said, what's wrong with you? They said, brain fog, joint pain, and fatigue. Well, I went to my doctor. He did an ELISA, and it was negative. But I told him I had Lyme. And the guy's like, you don't have Lyme in Florida. And at the time, there was almost no Lyme in Florida that wasn't from somewhere else. So did the doctor lie to the guy? No. But the guy went in fighting him, saying, I have Lyme. And partly it was his wife. But the guy had a TSH of 97. His thyroid stimulating hormone showed he was profoundly hypothyroid. I gave him thyroid medicine. And under 2 months, he was 100% better. So like I said, he had the symptoms of Lyme. It just wasn't, it was similar to something else, and it turned out it wasn't Lyme. I evaluated him for Lyme and thyroid and a whole bunch of other things because they all mimic each other. So we just need to find out what's wrong with people, not be hooked up, to all these things, So, there's a lot of, thank you so much for all these great questions and conversations here. Um, you know, and it's interesting. As I cruise here, one thing I wanted to touch on is that if anyone is interested, somebody asked like how long the waiting list is. I honestly have no idea. My 2024 goal is to stay in my lane. But what I do know is at the top of our website at OriginsOfHealth.com, and I'll drop it in there, but it should be in there somewhere. There's a thing to click here to apply. Both myself and Dr. Jess Montalvo are seeing Lyme patients. Jess has trained with me for over 3 years. I hand stole her from the universe, from everyone else's practice when she became available. Does an amazing job. But both her and I are seeing patients, and certainly there's some availability depending upon. I tell people all the time, sometimes you get lucky. I've had people on a waiting list for 18 months. I've had people on the waiting list for 18 days. It just depends on when you're available and when you ask. So I definitely do that. And then, kind of in closing here, just want to say thanks, like, for everybody's, super positive piece. We really, one comment was like, we got to get doctors, through the door. We got to be teaching at medical schools and doing CME. I'm actually in the process of working to get my Lyme training course CME certified, and then also creating opportunities for doctors who study with us, even if it's only at a 1-hour webinar, to get CME, because if we can offer them free or low level, and CME is continuing medical education credits, we need it to keep our license. And if we can start, it's just one more level to kind of get it out in front of everybody. We are, as soon as that gets done, I will be offering a Lyme basics course for, or maybe not basics. It's not the title's not finished, but an introduction, kind of like we're doing this month. I'm going to be offering that at a physician level to physicians, nurse practitioners, and PAs, so that they can get the benefit of this and not just have to watch like an hour or two on YouTube, but to actually get credit for doing it. And that's just, hey, it's mandatory. We've got so much on our plates. If we can make it better for them. So we're working on that. And there are people looking to get more in the medical schools. A lot of the changes, you see the openness of Dr. Steer, you see Mass General being more open. They're doing research, and they're still themselves, right? But they're more open. And part of that was a resident at Mass General who just basically said, look, in order to get Medicare funding, which all medical residents are, or residencies are funded by Medicare, you have to show you have to show sort of the whole playing field. It's like an equal opportunity thing. So if you're saying that there's only Lyme and it's only 10 to 21 days and it never goes longer, but there's another group that has substantial evidence saying it's this, you actually have to have the opportunity to show that. And that's what got Dr. Horowitz in the door. So we are making progress. Is it going as quickly as we would like? Probably not, but more and more students and residents are available. And, maybe what I'll do is do an online thing for residency. So maybe I'll pull all the doctors I know, I'll pull in places and do that. But yeah, so thanks everybody. And just, I know that someone just made a quick comment. And Marilyn, thanks so much for the love to Mom, love to all you guys. Mom is actually doing exceptionally well. Thanks to the ability, my family and my team at the office and my patients last Wednesday, who allowed me to kind of drop everything and come down here. And we've gotten things, pretty stabilized, and she's doing well. But all the love and the well wishes and the prayers are so appreciated. And yeah, more next time. Next week, like I said, we're going to go chronic Lyme for a couple of weeks, and we're going to be doing, get here on June 6th, right? I'm going to teach you guys about how to stress your body just enough and not too much. I'm going to give you an easy way to do that that's going to promote increased energy production, increased autophagy, which is intracellular detoxification. And I'm going to give you ways to modify what we're doing that anybody can do at any time. And then you'll have the recording to go over and over. It's all going to be science-based, but we're also going to talk about a bit about the stress piece and how much is good and also I'll give you a quick insight into physiologically what's going on when you're on a protocol and then it's going really well, but then it starts to diminish. How can you figure out if that's the Lyme and the Bartonella is just getting smarter, or if you're actually over treating and pushing the immune system and the nervous system too hard? When you understand this concept that we're going to be sharing with you, you'll be empowered to do it. Your doctor may be able to do it too, but more importantly, I want you to have that tool because it's really an introspection tool that gets applied to the science of what they're doing. That's really going to help you a lot. And if you want to know whether you go to 20 drops or you stay at 15 drops of whatever you're on, this is going to be a great tool for you. And really, I'm super excited. So it's going to be, learning this. And and one last thing, I do think that it is interesting that medical students are wondering why they're not learning it, but their friends are sick. This is a consumer-driven society. If the consumer, in this case the medical students, or in the other case the residents or the patients, need it and want it, it will eventually happen. We can make it go faster by using things. So anybody wants to head over to the YouTube channel and just hit subscribe, doesn't cost you anything. Every time you go and you create more comments like this, even if you sat here tonight, if you want to drop a few comments in, ask some questions, let's get a dialogue, because the more we do that, the more the algorithm puts us in front of other people. When we started this, because I've never really focused on YouTube until the last month and a half, when we started May, we had 650 subscribers. We're over 1,300 now. And that's basically just because of what you're doing in our video editor that I am so blessed to have, is super pumped to get this out. So literally over last weekend, we doubled our subscribers and we barely just got started. If you and your friends can help us with that, that is a way to get it out there. And go check out Instagram. God, I can't even say this out loud. Believe I'm saying TikTok. I have a TikTok. I don't do anything on it. My video guy puts it out. But LinkedIn, TikTok, Instagram, Facebook, just help share wherever your friends are. Share these resources so that they can have them. And it helps me a little bit, but it helps the mission and get this in front of people. It's almost like we need to start a Facebook group, which I don't even think medical students are on Facebook anymore, but Instagram or Snapchat or something medical students and residents for Lyme disease. Let's get this going together. And thank you so very much for sharing. Thanks for being here. And I will see you next week. If I do math right, it'll be May 22nd, 8 p.m. Eastern time, and super excited about this. Thanks for all the support in the chat. Thanks for being here, everybody, and we will see you next time.
So that's a wrap on today's eye-opening session. You're the heroes on the front line of your health, armed with knowledge and ready to win this battle against Lyme disease. And if this class gave you even one golden nugget of insight, consider subscribing to our channel. This is your go-to library for Lyme disease mastery and recovery. Your support means the world to me, and it fuels this movement. We need voices like yours to spread the word. So leave a big thumbs up, and in the comments, I'd love to know what your biggest takeaway from this class has been. What is that action step that you're going to take because you attended tonight? And then make sure that you share this video far and wide so that others can benefit just the same way you have. Because every view, every comment, and every like takes us one step closer to a Lyme disease-free world. So until then, keep up the momentum, keep learning, and keep taking action, because together we are unstoppable. So I'll be seeing you in the comments and can't wait to see you at our next class. Until then, stay awesome and all the best on your healing journey.